future attempt for surgical sperm retrieval or surgical reconstruction. In obstructive azoospermia, you can do a PISA, percutaneous sperm aspiration, or TISA, testicular sperm aspiration, or MISA, microsurgical sperm aspiration during a reconstructive procedure, or simple testicular sperm extraction by a biopsy. Of course, in obstructive azoospermia, it's very easy. Whatever the technique you do, you will have enough sperm to do ICSI. But in non-obstructive azoospermia is not the case. The more you do, the best you have a chance. I mean that if you do microsurgery, you have higher success rate in non-obstructive azoospermia than if you do a needle biopsy. But of course, it has its disadvantage, being costly and lengthy procedure. Regarding the optimal number of biopsy during an ordinary testicular sperm extraction, Professor Schlegel in 1988 found that there is no limit in the number of biopsy. Of course, the first and second and third, fourth biopsy are the most commonly site to find sperm. However, if you do more than one biopsy, you can always find sperm. In our experience, we have similar results, whatever the pathology is. So Schlegel in 1999 introduced the concept of micro-TISI. Few months after him, we were publishing our results, and we found a significant difference between conventional biopsy and micro-TISI. After that, many teams worked upon the same subject and showed the superiority of micro-TISI. And this meta-analysis was showing the superiority of micro-TISI over conventional testicular sperm extraction and the conventional one over the needle aspiration. The reason is simple. You can see beautifully the tubules of the testis, and you can select the most dilated one, and you can give the lab a minimal amount of tissue so they can do a good work on a little amount of tissue. In order to help the surgeon, we advise them to use a micrometer that they can put on the eyelets of their microscope. And we published our result in Fertility Sterility 2008, and we showed clearly that the higher the diameter, the higher the chance that you can get sperm. If you go to a diameter of 300 micron or more, 16 of 19 patients have positive sperm retrieval. 10 years later, Caroppo and in the team of Professor Oropi, they found that the seminiferous tubule caliber pattern, as evaluated at high magnification during micro dissection, predicts sperm retrieval in patients with non-obstructive azoospermia. They classified patients into group A, dilated tubules, group B, semi-dilated tubules, and C, non-dilated tubules. And they found that in non-dilated tubule, only 7% of patients have sperm retrieval, and in dilated tubules, they have 90% retrieval. In non-dilated, they have 47%. We found exactly the same number in our patients in dilated tubules and in slightly dilated tubule. However, in non-dilated tubule, we have a higher number of 23% sperm retrieval. However, in slightly dilated tubule, it's the double, and in dilated tubule is the double of slightly dilated tubules. But not only the surgery is important, also the role of sperm processing is very, very important. Shredding in fine mensing and meticulous and hard work during the OR by one or two biologists is important in order to detect sperm and to stop the surgery. However, in many instances, you don't find sperm during the surgery, and you need to do special sperm processing. Erythrocyte-lysing buffer is one of these techniques, and we published our results also a long time ago, and we found that it helped too much to find sperm because the erythrocytes hide the sperm behind them. Also, collagenase is very important and is a good addition, but in our experience, erythrocyte-lysing buffer performs better than collagenase. Also, if you add some pentoxypherin, you will find sperm moving easily between the cells. Finding sperm in testicular tissue may take 2 to 3 hours, and you have to do extended sperm search because you might find few sperm and you can save the life of these patients. The problem is what to do in negative testicular sperm extraction. There are some papers about giving gonadotrophin hormones in normogonadotrophic patients or giving HCG in hypergonadotrophic patients, but these are few papers and needs further paper and further control study to be sure that it might help. However, salvage microdissection is a very nice idea. If you have patients just redo with micro-TC, it will help. But the problem is what to do in negative micro-TC. Actually, the answer comes from a Turkish team last year, and they found that they have 18% chance in retrieving sperm in micro-TC patients, even if the testicle is small. And here they found that in the Klinefelter patient on redo, they have 50% retrieval, and in patients with tuberous sclerosis, 45% of chance to retrieve sperm. In our experience from our database, in patients with previous negative micro-TC, 13% of patients have a chance of redo. However, in previous negative ordinary testicular sperm, they have higher chance of 20%. What if they have done 2 trials before? If they have done 2 trials before of conventional TC, they have 16% chance of sperm retrieval. While if they have 2 negative micro-TC, we don't have the chance to find any sperm, unfortunately, in these patients. The reason behind it is the histopathology. So in cases of Sertoli cell only, you have only 12% of chance to retrieve. The same in primary spermatocytes. However, in early spermatid, you have a 40% chances to find sperm, and in hypospermatogenesis, you have 92%. So it's good practice to do testicular histopathology while doing a biopsy. But we have interesting finding regarding the semilunar tubule diameter. In previous patients with negative testicular sperm, if you have non-dilated tubule, your chance is only of 14%. While if it's slightly dilated, you have a chance of 25%. And in dilated patients, you have a chance almost 100%. Also, in previous positive testicular sperm extraction, when you are going to do a redo, if you have a non-dilated tubule, you have only the chance of 50%, while it's 83% if it's slightly dilated, and it's 100% if it is a dilated tubule. And these differences are statistically significant. While doing the operation or counseling the patient, you have the 2 options, either to do it a fresh biopsy as a day of ovum pickup or to do sperm freezing. Actually, this was a systemic review that we published this year, and we found that the frozen testicular sperm from men with non-obstructive azoospermia results in fertilization and clinical pregnancy with similar rate as those of fresh sperm. So this encouraged centers to use frozen sperm, and this was based on 3 meta-analyses confirming these results. In our practice, we prefer to do the fresh biopsy the day of ovum pickup when we are expecting a positive case. However, also we are asking the patient if he wants to do it in difficult cases with limited possibility to repeat the testicular sperm extraction, like patients with Klinefelter or very small testes. They have only maybe 1 chance in their life. But here the counseling is done, and the patient has to accept the low chance of retrieval. Of course, we can cryopreserve sperm if cryopreserve oocytes if no sperm is found. What about the results in terms of fertilization? Actually, functional azoospermia has less fertilization than obstructive, and obstructive azoospermia has less fertilization from ejaculate cases. This is from our database and our experience. The same goes for blastulation. In functional azoospermia is less than obstructive, less than ejaculate cases. However, when it comes to implantation, they all have the same implantation. When it comes to clinical pregnancy, they all have the same clinical, cumulative clinical positive pregnancy. The explanation for low fertilization and developmental rate of blastocysts is based upon the fact that testicular sperm are less mature and therefore less competent than ejaculated sperm, where further maturation occurs in the epididymis. And this is especially true in patients with azoospermia factor deficiency, as published by a Japanese team this year. So many people thought that PGT can help to improve ICSI outcome in this patient, as Denozo and Christina Magli and Samar Karamat. However, a multi-center team study by Mazili published in since 2 years, they didn't found the same. And they found that the equity rate and implantation potential of obtained blastocysts are independent from sperm quality. And they don't believe that it has to be applied to all patients. From our database, we didn't find also any difference between the fluid percentage between ejaculate and testicular sperm. So more data are needed to confirm the efficacy of PGT in this population. To conclude, I need to tell you that prior to surgery, patients have to do a precise semen analysis. Even an extended sperm semen analysis may be helpful. This will prevent to have unnecessary surgery for these patients. Also, hormonal assay and genetic tests have to be done. The chance of sperm retrieval will depend on your technique and on your lab. And it's true that unobstructed azoospermia micro-TC is the current standard of care and is prognostic in redo cases, as I showed you. Ineffective retrieval will deny the couples a treatment opportunity. The ability of sperm preservation offers an additional advantage, negating the need of synchronization of sperm retrieval and ovulation, and preventing repeat surgery and pointless ovarian stimulation in female partner. PGT is still a debatable option, and to have a good performance, we need to have a coordinated multidisciplinary team involving reproductive endocrinologists, geneticists, andrologists with microsurgical skill, and competent and devoted embryologists. Thank you.
Thank you so much, Dr. Amer, for this very elegant presentation, and I think I've enjoyed it thoroughly, as always. I have a question for you. When you do a testicular biopsy with your vast experience and find at the end of the biopsy that you did not get any yield from it, there were no spermatozoa there in that biopsy, when would you end your attempts? I mean, like, how further can you keep going? And if you keep going, is it beneficial or not? And then the second point is, would you consider in these situations to give some medical therapy and then come back again at another date? I have been there with you many times where patients referred with 3, 4 failed biopsies, and you do the first biopsy for them and find sperms. So there is something about the technique, but where do you put the period? Where do you stop in your technique? Thank you.
Actually, this is a very important question because even after redo, there is still a chance. But it's always difficult to define what is the chance percentage is for the patient. But sometimes, occasionally, these patients will give you a semen sample with few sperm. So my advice for the patient, even if you don't go for any treatment, is to do a semen analysis every 3 months with an abstinence period of 2 weeks or 1 week, and to go to a very specialized lab that do extended sperm search or meticulous sperm search. There's always a chance to find sperm. And I advise that all people working on this subject to have a good cryopreservation system to keep sperm if they found it, because sometimes it's once in the life that this patient can generate sperm. Regarding treatment option, I think that we need more researchers and we need to concentrate upon these researches, because maybe through hormonal intervention or some drug interventions, we can help these patients. And we have to look after the hormonal assays, because sometimes hormones are normal, but how they are normal? Sometimes you have FSH of 2. In the lab itself, it's normal, but FSH of 2 or 3, if you give hormonal therapy, this patient may have semen in the ejaculate. So I don't like to give up with this patient. I like to give them some hope. And I think that in the future, with elaboration of new technology, we can help them more.
Well, that brings us to the end of your presentation, Dr. Amer. Thank you so much for this very enjoyable presentation. I think because the time is short, we have to keep going, and we'll move to the next presentation. Thank you.
It is a pleasure to introduce Dr. Nino Guy Cassuto from Paris.